Welcome to Omnicurus Originals. We are celebrating the Diabetes Awareness Month, and today we have Dr. Adur Ashirvadam with us. Dr. Ashirvadam is a present chairman of RSDI Tamil Nadu chapter. Dr. Ashirvadam is a pioneering diabetologist in Madurai with 3 solid decades of experience behind him. He established the Department of Diabetology in Madurai Medical College and served there as professor and head of department for 14 years till he retires in 2013. Dr. Ashirvadam has his own hospital where his separate wing dedicated to diabetes was started in 1991. He believed in educating his patients, led him to release the first audio patient education cassette and CD, which was distributed to his patients free of cost. Dr. Ashirvadam is an academician and has been involved in educating medical and paramedical personnel. He also actively devotes his time to clinical trials and research projects. Welcome, Dr. Ashirvadam. The forum is all yours to begin.
Thank you. Dear friends, senior colleagues, and my dear junior colleagues, first of all, I would thank Omnicurus for having given me this platform to probably share with you certain simple primary or elementary aspects of diabetes today. And as you know, diabetes is a big, difficult problem to manage. However, it could be made very simple for the primary care physician to manage diabetes wherever he is, even in a primary health center, even a nook and corner of the various villages of India. You could practice diabetes in the right way and probably deliver the goods to the patients in a nice way so that you do a lot of work, or rather lot of commitment and service to the community in large. So today I'm going to talk to you on diabetes management in primary care. So this will be the fundamental management of diabetes, which every primary care physician, general practitioner, and people in the periphery should particularly know. And there are certain pitfalls which could happen. You should know how to identify it and prevent it. And it is not only a point of starting some therapy. The therapy should be effective, and it should be effectively intensified. So, dear friends, I will take you through a little bit of introduction to the topic. I will show you how diabetes management in a primary care setup could be given, and how do you avoid the common pitfalls, as well as how to intensify the therapy, and what are the targets that you should achieve, because achieving a target is the most important thing. And I will summarize and leave you with a few important conclusions. So, as you know, diabetes load in our community is so huge, and hence all diabetics cannot really be expecting to see a consultant and thereby get probably the best, within inverted commas, the best treatment. However, the same best treatment could be accessible to our patients in the remotest village or a remotest area from a general practitioner who is a primary care physician, who really needs a lot of knowledge input and probably delivering it to our patients. And as you know, it is not like a cardiology practice wherein you need a cath lab, you need a angio facility or a defibrillator machine, nothing like that. You require a very simple entity like a glucometer and probably strips for urine sugar and urine acetone, and probably that is more than enough to deliver the best diabetes care at the primary care level. However, you should be very careful to avoid the pitfalls at all times, and also monitor blood glucose, very important. And if the blood glucose is not under control, probably you'll have to just take the next step to intensify treatment, and there should not be what you call as a inertia of the physician, or you shouldn't be docile to just accept whatever blood sugar is there. You just give a tablet and be happy about it. It's not so. So that is about the most important aspect of it. So I will take you through what is the role of primary care physicians in the diagnosis of diabetes, particularly the early diagnosis, because that is very important. Then how do you manage a diabetic patient? Planning his diet. And how will you go about advising him exercise? And do we need to manage his stress? Because that is one of the important factors for precipitating diabetes, worsening diabetes, and probably develop complications of diabetes like even a myocardial infarction. And we'll talk about the oral glucose lowering agents as well as the injectables, the insulin and GLP-1 receptor agonist, and with a word of education at the end. So early diagnosis is very important. Why is it important? Diabetes is a disease wherein it is a silent killer. So it would remain silent for many years. It may not be visible at all. It may not be easily identifiable unless you do a blood sugar. So if you do a blood sugar for any person who is more than 30, do it once in 6 months so that you will be able to identify a patient to be in the pre-diabetic stage, which is very important, so that you could even reverse this patient to normalcy, or you could prevent the progression to diabetes, or you could give a good glycemic control and achieve the best treatment. So early diagnosis by routine screening of diabetic patients, and in the community for a person who doesn't know that he is a diabetic beyond 30 years, once in 6 months will be very ideal. The cutoff values are very important because sometimes many of our practitioners sometimes have a blood sugar check and probably ignore the borderline values and probably do not identify it quite early. So you can assess a person's blood sugar at fast state and 2 hours after postprandial state, or after glucose load, or after GTT. We will take up all these things later, but now for the present, if fasting is more than 110, that is diagnostic of IGT, and if postprandial is 2 hours postprandial is more than 140, it is called impaired glucose tolerance or IGT. So these two are pre-diabetic stages. And if you take a postprandial cutoff value of equal to or more than 200, it means that patient has gone in for diabetes. So also if the fasting blood glucose has gone more than 126, that is, it's not 140. If fasting is going up more than 126, that also tells you that it could be diabetes. And if it is going to be more than 140 in the 2 hour value, it is IG. So remember, two important values, 110, 126, 140, 200. So anything below this, 110 and 140 is normal. This 140, 110 up to 126 and 200 is the gray zone, or what you call as the yellow zone. You can always remember with a signal light. So this is the pre-diabetic stage, and fasting more than 126, postprandial more than 200 is a red zone or the diabetes. So whenever you see a signal light, green, yellow, red, so remember, once you go in the morning in one direction, remember our fasting values. When you come back in the same road, just recollect the postprandial values. So if it is less than 126, less than 110, it is normal, that is green. 110 to 126 fasting is a yellow zone, the pre-diabetic, and 126 and above, the red zone. So this is in the fasted state. In the postprandial state, remember two values, 140 and 200. Anything less than 140 is normal. 140 to 199 or less than 200 is IGT or pre-diabetic stage, and 200 and above, diabetes. So this is a very simple, correct diagnosis which you could do with a single prick or the glucometer. Maybe if it's going to be a borderline, you could even go give a glucose tolerance test or a glucose challenge test and do other things. But this is more than enough for you to remember at the periphery. The good news is that if you are able to identify IFG or IGT, you have got a lot of beta cell reserve. So you could prevent depletion of beta cell, as well as your arteries are quite healthy. So you can maintain healthy arteries, healthy target organs. So if you could convince the patient for an intensive lifestyle management, you could reverse him to normal, or you could even at least prevent progression to diabetes, keeping them at IFG or IGT. And as you know, proper treatment of recent onset of diabetes could even reverse diabetes if it is going to be less than 6 years in a small segment or a cluster of patients. And in a diabetic patient, if you could do a proper diagnosis and proper management, you could assure him of a near normal life and also free from diabetic complications. So the message is loud and clear that early diagnosis and proper treatment is useful. So how do you take up the treatment or management strategy? The first one is dietary management. So dietary management becomes a very important segment because the patient has a dwindling down beta cell. So the insulin secretory capacity is coming down day by day. So now you will have to live within the secretory ability of your pancreas. So long, even if you eat like a pig, your beta cells were on the top. So it was able to manage all those things. But today, the beta cells have come to an lowest ebb. So you will have to be careful in trying to live within the ability of your beta cell. So the quantity is important. And it is not only the quantity, the quality of food is important. And preparation also is making a lot of difference. What kind of oil is to be used? And do we really benefit by adding on fiber? Is there anything called food exchange, free food, forbidden food, and any alteration in the diabetic complication? So if you identify a person's height and calculate the ideal body weight, you try to identify them within the ideal body weight range and categorize them into three groups: the low or the lean, the normal weight, which is a range of 10% of either ideal body weight on either side, and beyond that you have the overweight and leading on to obesity. So this is called obese, normal, lean as far as our practical assessment is concerned. Depending upon the person's activity, you categorize them as sedentary, moderate activity, and severe activity. So just imagine 20, 30, 40. Very simple, easy formula. So if it is going to be 20, 30, 40 calories per kg body weight of ideal body weight. So this is for the obese, the normal weight, and the lean. If you are little sedentary, reduce 5. If you are a little more active, add 5. So that will give you the 9 numbers, the magic numbers, which are to be multiplied by the ideal body weight to give you the total calorie requirement. The total calorie requirement is something like your pocket money while you're a student. Maybe if you're well blessed, your father or mother would have given you some 10,000 rupees per month as a pocket money. In that particular amount, what do? You take some amount for your mess fees. You take some amount for your birthday celebration. You take some amount and plan the budget for buying some books. And maybe for going for a movie, things like that, you have some more allocation of funds. In the same way, you are to plan your calorie requirement in such a way that the patient should be having equally distributed calorie almost throughout the waking hours of the day. And how do you go about doing that? You divide the total calories by 4. So for easy calculation, I'm not very good at mathematics. Probably if I had been very good in mathematics, I would have become an engineer. So I think you can understand. So easy number would be 1,600. So 1,600 divided by 4 would be 400 each. So 400 for breakfast, 400 for lunch, and 400 for dinner. What do you do with the rest of the 400? That you divided by 4. So that would be 100, 100, 100, and 100. So this is for early morning snack, mid-afternoon snack, evening snack, and bedtime snack. So totally it will be snack, breakfast, snack, lunch, snack, dinner, and snack. So almost the entire wakeful period is covered by distributing the calories in a very equal manner. So this is how you plan the allocation of calories, and then the meals and materials are chosen after discussing with the patient, just like what he would like to have for his early morning snack, what he would like to have for his breakfast, for his lunch and dinner. A South Indian person would like to have some idli or dosa. A North Indian person might like to have some chapati. So depending upon that, you can plan sitting with him, and this is called meal designing. So this is how you do a quantitative analysis and planning. And then what are the qualities that you should really have in mind before planning it? There are certain food material which have high glycemic index. They are like potatoes, white bread, which are to be avoided. Maybe we avoid potatoes because we are primarily rice eaters or probably wheat eaters. Whereas in the Western world, particularly in the European community, potatoes are very important. So they can't afford to forget potato, but they are not going to take up rice. So in that way, they could exchange for rice with potato. And what he really means by glycemic index is that the ability of the food material to elevate the blood glucose, comparing it with glucose. So if it is closer to glucose, the high glycemic index, like 100, 99. If it is close to 0, it is like a high fiber diet, like the greens and vegetables. Rice, wheat or ragi, not much of difference. Maybe a little bit of protein is more with wheat and ragi. You can allow it for the patient's choice. We don't recommend gruel because gruel is a dissolved form of or a semi-liquid or a semi-solid material which hastens the absorption. We don't want the absorption to be faster. We want the absorption to be slower. So here, you don't give it in the form of a gruel, but you give it in the solid form. Wheat chapati is okay. Wheat flour made into a gruel, not recommended. And then in the principles, refined carbohydrates are avoided, like sugar, honey, jaggery, glucose, whereas complex carbohydrates like starch, food like rice or chapati, all these things are acceptable. And in the various components of the meal, carbohydrate, protein, and fat ought to be distributed in the ratio of 60 to 65 carbohydrate, protein 15 to 20%, and fat 15 to 20%. In the preparation, raw food is always better. It doesn't add on any calorie. Because if you just take a bitter gourd, very good, healthy food, but if you just do a deep frying, it becomes an oxidated entity, that is with some thawing, as well as with oil, it becomes little more unhealthy. Bigger pieces of vegetable cutting is better. Boiled is better than fried, because boiled does not increase the calories. So a boiled chicken or a boiled fish is better than a fried chicken. And you need not have a separate cooking for diabetics at all. The same food that you prepare for the other people at home is the same for diabetic patients also. Regarding oil, it is always very controversial. Lot of changes have been taking place day in and day out. But as it stands today, saturated, monounsaturated, and polyunsaturated fatty acids are in the ratio of 1:1:1. And in our part, gingerly oil is the better. And sunflower oil is quite good as it has more of omega-6 polyunsaturated fatty acids. But lot of oxidative stress is more likely. Even ghee, 1 teaspoon per week, is acceptable because ghee contains many of the good fatty acids which are not available cannot be synthesized in the body. What are called the essential fatty acids. What is the role of fiber? Leafy vegetables, legumes, and pulses contain high fiber. The advantages are it reduces the rate of absorption of carbohydrate. So the beta cells, which have become little sluggish, the sharp first phase is not there. So it is sluggish insulin secretion. So now the food is made to get absorbed in a slow pattern to match the sluggish insulin secretion. It also forms a bulk of feces. Thereby, even if you restrict the quantity, you have a normal evacuation. Reduces cholesterol and also acts through the incretin pathway by suppressing glucagon. However, it also has some disadvantages like flatulence and vitamin deficiency. What is this food exchange? To break the monotony. See, if I am asked to take only a cup of coffee every day, I'll become terribly bored. So I can take coffee today, tea tomorrow, 100 ml of milk next day, maybe a lemon with salt one day, buttermilk on another day. So this type of changing of food gives you a little more satisfaction, and the adherence is better, compliance is better. So also fruits. Today you can have an apple, tomorrow you can have a sweet lime, next day you can have a guava fruit, other day you can have some 10 grapes, some 5-6 pieces of papaya, some 3-4 pieces of mango, or probably a banana. If it's going to be small, one banana, or if it's going to be a big one, half of it. What is this free food? Free food is a low-calorie, high-fiber substance. So things like vegetable salad, onions, popcorn, cucumber, and greens, which could be taken in a little more excess quantity to avoid hunger as well as sense of satiety. What are the forbidden food? Sweets, sugar, honey, jaggery, smoking, alcohol, ice creams are to be avoided. So the message is clear that a normal quantity and quality restricted planned diet is recommended in diabetic patients. So it is no longer a stale food, no longer a boredom food, but it's the same thing that you have been having so long with little bit of modification here and there. What about exercise? Exercise could be classified into low intensity, moderate intensity, and vigorous intensity. So low intensity is something like what you are just walking along, slow stationary cycling, or cooking, or attending to your routine work at home. Moderate intensity is something that you do something fast, you feel little breathless, but you could talk comfortably, maybe like jogging. And vigorous intensity exercise means that you are doing it in a very serious manner, that you will have lot of breath, lot of increased rate and depth of respiration, that you will not be able to talk more than few words. In simple words, if your strolling is less than 3 kilometers per hour, it is low intensity. 3 to 6, moderate, or is equal to jogging. More than 6 is running, and it is a vigorous intensity. So some form of exercise has to be done by not only your patients, but you. Are you doing your exercise every day? Start your exercise today, not tomorrow, today. Because exercise is one thing that could always be useful from the what you call as a cradle to probably the grave. Anytime, exercise is so important. So the another important thing is, in Indians, we have been recommended by the Asian guidelines for 60-minute exercise every day. We should at least have 30 minutes of moderate intensity activity, some 15 minutes of lesser activity, that is work-related activity, and 15 minutes of muscle strengthening or isotonic exercise. So if you are able to do that, that's wonderful. That's the most important thing that you could do for your body and to prevent all your drawbacks. So exercise forms a foundation to manage insulin resistance. As I was telling you, food or dietary pattern is to compensate for the reduced insulin secretion, whereas exercise is to have an effect on the insulin resistance, because exercise reduces insulin resistance. What about stress management? Mental stress increases anti-insulin hormones and cause or may worsen diabetes as well. And reducing stress improves insulin sensitivity. Measures like yoga, meditation, relaxation reduces the release of stress hormone like growth hormone, catecholamines, corticosteroids, and ultimately this reduces insulin resistance. So it is not only yoga, meditation, relaxation. You sit and chat with your friends, enjoy. You go for a movie, laugh and come back. That itself is a good relaxation. So try to do some relaxation maneuver so that you enjoy it and you are free from the stress. Prevention of stress could also prevent or postpone onset of diabetes and also achieve good control of diabetes as well as blood pressure also. I have seen in several occasions when there is a stress in the family by loss of one loved one, the other person develops diabetes, or the diabetes in the other person worsens and that person also develops another problem like an acute myocardial infarction and dies. So remember, stress management reduces anti-insulin hormones and reduces insulin resistance. And so adrenaline, noradrenaline, when it comes down, you are a little more safer. Coming to the low oral glucose lowering drugs, I am not going to tell you about all the names, the milligrams and the dosage because you know all those things. But in simple words, what are the secretagogues? So sulfonylureas, particularly the newer generation of sulfonylureas like glimepiride and gliclazide are insulinotropic drugs. And ripaglinide is the brother or cousin brother of sulfonylurea, which also sits by the close to the sulfonylurea receptor and acts in a similar way, but it is not a molecule related to sulfonamide. So that is the advantage of ripaglinide. And the advantage, one more advantage is that it is a fast-acting and a short-acting drug. So hypoglycemia is less. And DPP-4 inhibitors are also insulinotropic drugs, but the crown of DPP-4 is that it is a glucose-dependent insulin secretion. So if the blood glucose is high, adequate secretion of insulin would be happening. If blood glucose comes lower to euglycemia, the insulin will be shut off and glucagon will be gradually started to release. So it is a glucose-dependent insulin secretagogue. What about metformin and pioglitazone? They are insulin sensitizers. So they improve the insulin action and thereby improve what little insulin the patient has got. And very often you may require a combination of both. What is this acarbose and voglibose? They are the alpha glucosidase inhibitor. They reduce the rate of carbohydrate absorption, almost like what a fiber diet does. But this helps to avoid the breakage of disaccharide. Thereby, monosaccharide availability is reduced gradually, and then gradual absorption takes place by reducing the rate of carbohydrate absorption. The new drug, SGLT2 inhibitors, are wonder drugs. They dispose glucose to the kidneys. So it is almost like an emergency exit in a cinema theater. You see, as you know, you have an entry of the cinema theater, entry gate, which is quite narrow. Probably an obese person has to just sneak into it or squeeze into it. But whereas in the interval, they open all the doors quite wide open so that all the people go out, have a snack, go to the toilet, ease themselves, and then come back. Or in case of an emergency, they could be disposed of just like that. So SGLT2 is not like a glucose utilization by the peripheral muscle tissue and lipid tissue and other tissues, liver, but it is almost like shunting blood glucose outside. So this does in minutes and a lot of glucose is disposed. So this is one new drug which has been the very good drug having not only the glucose reducing action but many other actions. So what you do is choose an apt drug for that particular individual, combine it with one or two of the drugs, and it has to be individualized. Now, how do you go about planning a medication, oral medication for a diabetic patient? The first line therapy is metformin, apart from the lifestyle modification. Why do we say so? Metformin is a cheap drug, number one. Number two, very efficient drug. Number three, it reduces the insulin resistance. Thereby, you don't deplete the beta cell mass in the pancreatic beta cell. And next is, it does a lot of wonders in reducing cardiovascular mortality. It also reduces the benefit of weight. So if you are a little obese, the patient also would lose weight. So a lot of benefits are there with metformin, and even cancers are less with metformin. So metformin should be the first drug for a diabetic patient unless the patient is not able to tolerate or patient has some contraindication for metformin. The next step is, what is the second drug? So it is almost like you are going to look for a bridegroom for the bride metformin. So which bride would really match metformin? You have several compelling indications. So maybe even in any marriage bureau, they would always like to give you several options. Do you need a housewife, a girl, or probably a working wife, a professional person, or probably a person who is very homely? All these options are given. In the same way, the second molecule, which I attribute to as a bride to the metformin, is chosen according to the comorbid conditions. If this patient has a very high risk of a cardiovascular problem, or what he called as a ASCVD score, it is dependent on your family history, your weight, your BP, your lipids. All these factors are considered into the atherosclerotic event score. And if that is on the higher side, you will have to protect the patient from increasing blood glucose and the cardiovascular problems, which could happen much more commonly in the diabetic population. So the drugs which have been proven for this particular efficacy as well as reducing the mortality are the GLP-1 receptor agonist as well as SGLT2 receptor. We'll be discussing about SGLT2 a little later. So I've already told you that SGLT2 is a wonder drug. So it reduces the blood sugar as well as takes care of the cardiovascular problem prevention, also the renal deterioration, and probably in days to come, it could be the drug for the liver problem, what you call as a non-alcoholic steatohepatitis. So in days to come, it may be an approved drug for that. requirement of the bride, as I told you, is CKD or heart failure. In this segment, the first drug of choice would be SGLT2 and the second drug of choice will be GLP-1 receptor agonist. So that is about the two important requirements. The third requirement is that the person should not go in for hypoglycemia. Metformin does not produce hypoglycemia. So if you combine metformin with any of these four, a DPP-4, a GLP-1 receptor agonist, an SGLT2, and thiazolidinedione, any of these drugs would also be not pushing the patient to hypoglycemia. So this is a very safe combination and probably to be used much more common so that the patient will have a near normal life and he would not even feel that he's a diabetic. At the same time, blood sugar will be under good control. The next requirement is weight reduction. So if this patient wants a weight reduction, you will have to choose the two important drugs, particularly GLP-1 receptor agonist, which has a very good weight reducing effect, and SGLT2, which also has some weight reducing effect. The last one is the cost. If the patient is not able to afford, probably you could use a sulfonylurea, glimepiride or gliclazide, a thiazolidinedione, and probably today we have a cheaper gliptin as well as cheaper thiazide, the teneligliptin, and we also have the remogliflozin, which are all, this is about cheaper. All these things are to be included in our Indian setup. So this is how you choose a second drug. And then you need a baby. So the third add-on would be either or the other one in the same group, or probably you could choose it from the other group till you have the 3-drug combination. Just like the family planning program, V2, ours 1. The same thing holds good here also. If you have 3 drugs on board, beyond that, adding on the 4th, 5th, 6th, and 7th may not really achieve great things. So you may have to go in for insulin, or probably you could add the 4th one or at the most 5th one. But ideally speaking, beyond 3 is better that you take up insulin. What about the injectables GLP-1 receptor agonist? Liraglutide, dulaglutide, lexinitide, or all the GLP-1 receptor agonists. They are incretin-based therapy. They are GLP-1, but not the real GLP-1 which is available in the body. And when you give them as an intramuscular or a subcutaneous injection, it roams around the entire system and not inactivated by the enzyme called DPP-4 because it is slightly different from the body's own GLP-1. So it is not broken down by DPP-4. At the same time, the dosage has been given is slightly on the higher side, what is called as a pharmacological level. So with that, it reduces blood glucose by acting on the beta cell. It also acts on the alpha cell depending upon the glucose levels. It reduces the body weight and also has a lot of CV benefits. Hypoglycemia is minimal or probably no. And nausea or vomiting may be occasional. So I always tell my patients, you might experience a symptom similar to your morning sickness. So probably every husband would have witnessed the morning sickness of his wife. So probably that will be a simple analogy for you to have an idea about the drawbacks of GLP-1. And as you know, after morning sickness, they are going to have a very nice time of getting a baby. The same way after GLP-1, with a little bit of morning sickness type of symptoms, you are able to get a very good glycemic control, no hypoglycemia, weight reduction, and cardiovascular benefit. Coming to insulin. Insulin is a very important drug and probably the king of insulin, diabetes therapeutic armamentarium. And insulin is available for almost 99.8 years now. So in another few months, we will be celebrating the centenary for insulin. And probably you should know the insulins which are available at present are human insulins and analog insulins. In the human insulins, there are 3 categories: the short-acting, the intermediate-acting, and the premixed insulin. So if that is so, these are the trade names which I have given you, and there are analogs. What is this analogs? See, we have come long way from a bovine insulin, then porcine insulin, and we have achieved what is exactly available in the human body. Now, what are we going to achieve beyond this? Yes, we have achieved it. And what is that? Even today, in spite of so much of research, so much of discovery, 100 years of insulin therapy, we have not been able to deliver insulin in the portal circulation as it is normally done in the human body. That is the greatness of God's creation. Whereas what we could do is to add on an insulin at the periphery. But what happens when you achieve it in the portal circulation is that you are able to get a maximum concentration in the liver, and there is conversion of glucose into glycogen, and rest of the things achieve a circulation at the periphery along with insulin. Thereby, all the glucose is disposed into the tissues. But what we do is injecting the particular insulin in the systemic circulation, and that has to go all the way around to the hepatic artery and then reach the liver, and then effect be in the coming to the right atrium, then getting into circulation of the arterial system. So these are the areas of little difference between the endogenous insulin or the God-given insulin and the man-made insulin. So these two insulins do not really have the same action. The insulin that you are injecting in the arm or in the periphery is taking a lot of time to achieve a good control. It takes a longer time to have a peak, and it stays there for a longer time and then takes off. So this is little difficult for achieving a good glycemic control. And the same way, if you want an insulin to act for a longer time, the intermediate insulin from the human variety has certain drawback of a peak because it is merely a mixture. And when you combine these two, you have a advantage of pre-mixed insulin. Whereas in the analog category, the ultra or fast-acting, short-acting, ultra-short-acting, rapid-acting insulin, or Lispro, Aspart, and Glulisib. These are insulins which are independently suspended in the vial. Whereas in the human insulin, six molecules of insulin are attached to 2 atoms of zinc, and it is suspended. So if you inject a human insulin, it takes longer time to dissociate 2 and 2, 4 and 2, 3 and 3, then 1 and 2, and this one starts acting. Whereas in the ultra-rapid acting insulin, all insulins are available as monomers, and hence this starts acting at the same time, achieving the sharp first phase-like action, even though you have injected it in the systemic circulation. The long-acting insulins are the insulins which don't have a peak at all. And this has been achieved by making it as a depot at the injection site and the release of molecule one by one in a phased manner or in a regulated manner. Sometimes you have an insulin which is getting attached to the albumin, to the tissue, and from there it is released. All these things achieve a flat curve of basal insulin. You also have a mixture of this, the pre-mixed insulins of analog variety, as well as co-formulation. So this is nothing but a combination of the short-acting, ultra-rapid-acting insulin and the long-acting analog, which will be helpful. And there are certain variations between Lispro mix and Aspart mix, which is nothing but a protominated ultra-short-acting insulin, which is almost equivalent to that. So ultimately, we have got designer insulin. Just like a designer wear, designer shoes, you have a designer insulin today to really have the real need and probably the effect of this insulin. My idea and my request would be, do not hesitate to start insulin. That is why I told you, beyond 3-OHA, it may not be really useful, and don't hesitate to start insulin therapy if a patient is not under control with the OAD. So this is the flow chart for the insulin usage. So when the patient is on lifestyle metformin, if not under control, you add the second group of drugs. If still blood sugar is not under control, you divide the group into 2. Patient with high fasting blood sugar alone and high fasting and high postprandial group. In the high fasting blood glucose, start with basal insulin. And if the high fasting, high postprandial, you start with a premix with a short acting and the basal insulin together. I try to achieve control. If not possible to that, try to titrate it up or down depending upon the blood glucose. If they are able to achieve a hemoglobin A1C of less than 7, well and good. But if it is going to be more than 7, you may have to intensify. So the basal insulin may be intensified by adding another short-acting, ultra short-acting insulin called the basal plus, or another 2 or more injections, making it a basal bolus therapy. Whereas when you give a premixed insulin once a day, you may have to intensify it with a premixed insulin twice a day, what you call as a mixed split insulin, or you could even use it 3 times a day to achieve a tight glycemic control by intensifying the premixed insulin. So ultimately, you will end up with basal bolus insulin or the 3 times a day premixed insulin analogs. So that is about the treatment modalities that we have at the moment. And there are certain pumps which are very helpful. They just infuse the insulin depending upon your programming of the pump, which will be helpful in type 1 diabetes, pregnancy diabetes, and certain brittle type 2 diabetes. And you have some more drugs like bromocriptine quick release, drug like hydroxychloroquine, but they are less frequently used drugs, so I have not mentioned any of them. Probably during question hours, I could answer anything of that particular variety. So dear friends, we have now come up to the treatment modalities of diabetes and what are the common pitfalls that we could come across while managing diabetes. Patients' management as far as the lifestyle is concerned is always very, very difficult. I don't know how many of you have been very careful with your weight and managed your lifestyle. It is very difficult to maintain weight. It is very difficult to curtail food, and all that it decides is 1.5 inches of your tongue. Just for the taste of it, you gulp like a pig. So eating becomes abnormal and finally results in a poor control or probably the onset of diabetes. And even however much you tell them, lifestyle modification like diet as well as exercise and stress management, you're likely to go elsewhere or go astray. So this is where in every visit, you should try to talk to the patient. How about your diet? What are the things that you had for the last 2-3 days? You just analyze. You'll be able to spot out the mistakes that the patient does it. And exercise. Patient would not have been regular with exercise. Or patient would not have been having any relaxation exercises or relaxation maneuvers. Teach them how to inculcate this habit in an enjoyable manner. So what I always used to say to my patients are, if you're going to be a little serious about an exercise, you might not do it. So what you do is, you buy a treadmill or probably an elliptical, do an exercise in front of a TV, put up a particular movie or a comedy scene or probably some music, some dance. No? You will enjoy looking at a particular movie or things like that, and you will finish off the exercise without difficulty. That'd be wonderful. Then regarding meal, you try to give them a various meal, particularly breakfast, in South Indian meal, you have idli, dosa, you have pongal, idiappa, pongal, upma, and probably even bread. So any of this could be accommodated. So if that is so, that means he will have a psychological satisfaction of eating. So he will not be very avaricious in eating. So that would be the management of dietary pattern. And stress management, as I told you, also has to be stressed, assessed at every visit. The second thing is that you check your blood sugar, and the blood sugar is very high. So you would have already given 1 tablet, say glimepiride 1 milligram twice a day. So what would you do? You will automatically increase the tablet to 2 milligrams twice a day. But before adding on, check whether the patient has been regular with his tablets, regular with his lifestyle management. If these 2 things have not been proper, if you are going to add on a 2 milligram twice a day, you will end up with hypoglycemia. So recheck the lifestyle, recheck whether he has taken the tablets regularly and on the day of test, and then decide about increasing the tablet or decreasing the tablet. All these things could be solved only by proper education. Hypoglycemia also may lead to less motivation towards tight control. I have seen many patients whom, when they have their first hypoglycemia, a severe form, They are scared of tight control. They would rather be having a high blood sugar, hemoglobin A1C more than 8.5 and be happy rather than achieving a 7% hemoglobin. But the good news is that today we have a lot of medications which are very good. You can achieve hemoglobin A1C of 7 without hypoglycemia, without weight gain, or probably even with weight reduction, with cardiovascular mortality benefit, with renal deterioration prevention benefit. So all these things are today available. So make use of it and do not allow our patients to go in for hypoglycemia. However, always give them an ID card for hypoglycemia, some glucose powder or a glucose tablet, always to be in their pocket, and also educate them that they might develop hypoglycemia on some day or other. So they need not worry about it, and they should always have it in their pocket or within almost accessible in their body. If they're going to have it in the table, if they're going to have it in the purse and have the purse somewhere else, they may not be able to take it up. So teach them, very important. Then another drawback which you commonly see is swapping of the tablets. This patient goes and talks to the other patient, and the other patient says, oh, my doctor gave me this tablet and that was very useful. So this man goes and takes that particular tablet for him. That such a thing should not be done. You should not encourage that. So educate them. If they have a liking for the tablet, they could always get the name of the tablet and discuss it with you. And if you find that this will be useful to him, then you could change it, or else you can continue with this original prescription. So all these things could be achieved by patient education. My teacher, Professor Sam J.P. Moses, always used to say, diet is one limb or one arm or one leg, and exercise is the next. Tablets, the third. Insulin is the fourth. And with all the four legs, what do we achieve? Nothing. Without a tabletop. And the tabletop is education. So educate your patients. Unless you educate them, they will never be responsible. They will always look at you and say, why my blood sugar is not under control? Unless they take the responsibility, they know that they are also important and responsible for blood glucose maintenance. If you make it that way, your job is half done. And lastly, education gives them the real empowerment to get into the real area of good lifestyle management, good option of choosing your doctor, choosing the tablet, choosing the insulin, and also managing his glucose monitoring at home. Very important. And also, if he's sick, the sick day rules have to be taught, and also urine acetone has to be mentioned. Fixed drug combinations are really a boon to this. The regimen should also be simple and also pocket friendly. The FDCs are a little cheaper. When you combine two tablets together, it is put together is cheaper when compared to taking these tablets separately. So this could improve compliance. The number of pill load as well as the purse load is reduced. So the compliance is better. And in insulin therapy, the dosage, the regimen errors, the drug-related errors, administration errors, and monitoring errors could happen. And this should be prevented by proper education. So that is where the general practitioner finds it difficult to start a person on insulin and probably adds on the fourth and the fifth and the sixth and the seventh OAD. But a consultant has some people with him to talk about insulin, to just demonstrate the way of getting the injection and the rules of injection. So when you have a facility of that, insulin therapy starting, it has become very simple. So the last lap of my talk would be effectively intensifying therapy. Unless effective tight control is achieved, there is no use of treatment. Those days, there were no treatment for diabetes at all. Then came an OHA. So once that particular OHA came, people thought, you just put that particular tablet and fit and forget. But today it's not so. You have to achieve a target. If you have not achieved a target, there is no point of your treatment. So it is almost like an all or none law. If you have achieved it, well and good. If you have not achieved, no use. The next is avoid clinical inertia from the beginning. So hit hard, hit early. So once you diagnose a patient to have diabetes, you should be very energetic and motivate the patient so that he comes under control within a month. and remains in good control from the beginning, which gives you a very important concept called legacy effect, wherein the complications are much less when you start treating him from the beginning and keeping him under good control. The next important thing is early combination of medicines now prove that the control is better and the durability of control is also well established. We have had a trial called Verify trial, which was a combination of vildagliptin and metformin from the beginning. So that gave a 5 years control, good control, less of complication and good durability. So to have all these things in mind and always intensify therapy from the beginning. Start insulin early, what you call as the early insulin therapy, which will reduce the glucotoxicity and offer them a better beta cell reserve so that the long-term effects are better. If not early insulin therapy, at least start insulin as early as whenever there is a failure of OHA. The second one is that it is not only initiation that is important, you will have to up-titrate it and achieve a good glycemic control. If you have achieved that, maintain. If you have not achieved it, intensify the therapy as days go by with a basal plus, pre-mixed, or ultimately the basal bolus therapy, because the beta cell mass is not going to last longer. I have seen an ad in the petrol bunks, petrol stations, wherein it should be mentioned those days, oil is not going to last forever. So also insulin or the beta cell is also not going to last forever. So if today he is under control, that is not the end of it. Tomorrow he may go out of control. So you see to it that you intensify the treatment. You require more heroic measures later in the diabetic life rather than in the beginning. So try to achieve a good glycemic control by intensifying therapies from the beginning till the end. And what are the targets that we should achieve? A minimum target is a thing which I have put it here. Less than 110, very nice. Less than 160 postprandial, very nice. But at least not more than 130 fasting and 180 postprandial. And the hemoglobin A1C of less than 7. But the targets were common those days. But today, it has to be individualized. A person who is having a lot of comorbid condition and other things, it should be relaxed to some extent. Should be individualized and it should be achieved and maintained. So what is the target for person A might not be the target for B. For one person, it could be a hemoglobin A1C of less than 6.5. For another person, it may be even 7.5 to 8. So all these things depend on the age, duration of diabetes, comorbid condition, the level of motivation, and the family support. So all these things should be achieved at the earliest and maintained till the end of it. So dear friends, to summarize what I've been talking to you for the last 40-45 minutes, early diagnosis and proper treatment is useful. A near normal quantity and quality restricted planned diet is recommended. Exercise form a foundation to manage insulin resistance. Stress management reduces anti-insulin hormones and insulin resistance. Choose the apt drug or appropriate drug or the appropriate combination for the individual patient. And do not hesitate to start insulin if patient is not under control with the OAD. Anticipate pitfalls and prevent by proper education and care. And above all these things, avoid clinical inertia to intensify therapy and always achieve targets. As you know, the pharma people are always bothered about target of sales. We are bothered about the target of achieving control. So to conclude, dear friends, the primary care physician has a first contact and he is much closer to the patient when compared to a consultant. And he should be empowered to manage diabetes in an efficient manner from the beginning. And prevention of progression from IGT to diabetes, early diagnosis and targeted treatment, proper monitoring and identifying the timing of referral to prevent complications are important. So it does not means that you'll have to manage the patient till the end. Moment you find that the control is not achievable or if the patient is developing some complication, try to send them even before the onset of complication because the patient can always be benefited by the different choice of drugs and also a multidisciplinary management so that diabetes is not limited only to diabetologist, but also podiatrician, a diabetes specialist nurse, a cardiologist, a surgeon, a gastroenterologist, as well as a nephrologist and a neurologist. So all of them are an important portion of management of diabetes. And once you really do that, you can achieve a good control in the primary care as well as the tertiary care. So I've got a few questions in the chat box. Tell us a little more about diabetes management in pregnancy. Diabetes management in pregnancy is a very important segment because that involves the primary, or what you call as the primordial prevention of diabetes. So you are treating a diabetic pregnant lady and giving her the best outcome, number one. Number two, you are trying to treat that particular baby. If the intrauterine environment is good, the child developing diabetes later on would be much less when compared to an intrauterine environment wherein the blood glucose was high. So this is called primordial prevention of diabetes for the baby. How do you treat it? So there are two types of diabetes. One is diabetes patient getting pregnant. Another thing is called gestational diabetes. So gestational diabetes is a simpler one, and diabetes marching through pregnancy is a difficult one. And type 1 diabetes marching through pregnancy is a most difficult one. Whatever it may be, identify the diabetes diagnosis. Number two, the first and the foremost modality of treatment is insulin. These patients have a very low fasting and very high postprandial. So probably you'll have to intervene with a shot of insulin for the postprandial rather than the fasting blood glucose levels. So try to put them on a short-acting analog like Lispro or a short-acting human insulin at the morning breakfast, lunch and dinner if it is going to be a diabetes pregnancy. Maybe if it is going to be a gestational diabetes, it's a little simpler form wherein you may just need one premixed insulin once a day if the patient is not under control with diet and exercise alone. Coming to regarding diet, the diet has to be still more divided. As I told you, I gave you 7 components of diet or 7 packages of meal. But here it should be little more. 2 breakfast, 2 lunch and 2 dinner. If you are to take 3 chapatis, make it 2 and 1. If you have to take 3 servings of rice, make it 2 and 1. In that way, you split the meal and cover it the entire period. Idea is the fasting hypoglycemia will be avoided. At the same time, if you take little more in a particular meal, the blood glucose rise will be high. So that is why split the meals. And the next one is if the patient has got a bad obstetric history, the patient may not be advised walking. In that way, in that situation, you could still advise the upper limb exercise. If you give upper limb exercise like this, just raising the hands up this way, forward, backward, things like that, that would also give an important insulin sensitivity improving maneuver. So that exercise could be given. Diet could be split and given in 24 hours period. And the third drug therapy is insulin. Metformin could be added, particularly in a patient who has already been on metformin for a PCOS. That is the absolute indication of metformin. In other situations, it is a drug of the second order. OHAs have been tried in some of the pregnancies, but I would not recommend any of you to try a OHA in pregnancy unless it comes to the mainstay of treatment as far as evidence-based medicine is concerned. So that's about diabetes pregnancy management. I will take up the second question. Ram Babu Paidi, cataract risk and management in diabetes. The cataract risk is always higher. It occurs more number of patients. It occurs at the more premature period. And in type 1 diabetes, several patients have had cataract in a younger age group, 5 years, 10 years, 15 years. I have seen cataract. And those days, IOL was not available. So what happened? You had to necessarily take off the lens and put a thick glasses for these patients. Very pathetic. So premature cataract, and also more number of patients develop cataract. What is the treatment? Today you have got the best, excellent IOLs. So it could be a natural fit for even the young or the old. Apart from that, even if you do a laser later on, the lens will be able to withstand. So dear friends, don't worry about it. If you develop cataract, you keep them under good control with insulin, subject them for surgery, and finally take them off from insulin if it is not needed. They would definitely fare very well. The next question is from Rahul Rajawat. Oh, it was a comment and a compliment. Thank you, sir. Thank you very much. The next one is Vinesh Sukumaran. Drugs of choice in elderly to avoid hypoglycemia. Very important question. As I told you, the geriatric age group is always a difficult one. And here, the first drug you could use is metformin at a low dosage. Though the total dosage allowed in a metformin is 3 grams. But we never usually go up to that. Maybe 2 grams in robust individual. Maybe 1 gram for a normal person. And for a elderly person, 250 milligrams twice or thrice a day, more than enough. The next drug of choice would be DPP-4 inhibitor. Wonderful drug. Very many DPP-4s have been tried in elderly population like vildagliptin and sitagliptin. And this drug does not produce hypoglycemia, very safe. Thiazolidine could also be used, but the drawback is that there may be any incidents of fracture. So it could be the third add-on. SGLT2 is again a good drug. That could also be the third add-on, because in the rare situation of dehydration, that could probably be there may be little more drawback. So that is the combination that you might require in this particular situation. And the next question is Nakiket Achilles area. So are there any guidelines for choosing the different groups of antidiabetic medication while individualizing treatment for a patient? So what I'm trying to tell you in this particular talk is that you identify the patient as diabetes, put them on lifestyle and metformin, start with a lower dose, increase it to at least 500 milligrams twice a day, 1 gram total dose, then see how you really fare. If that patient fares well, stop with that. That's more than enough. Now, if the patient is not under control, you have the several options. In that option, you could go in for the first option. As I told you, DPP-4 is a very good option because that has no weight gain, no weight loss, no hypoglycemia, efficient drug. So ideal situation to add on metformin to DPP-4. If the patient is a robust individual, normal person, you could add a SGLT2 as a second add-on. So these are the two important drugs which have come beyond sulfonylureas as a second add-on. The third add-on would be the other one, which you have not used it that way. And probably the third one would be a similar one, which you could add on. Beyond that, try to think of adding a alpha glucosidase inhibitor, which is a quite good drug for the elderly as well as for a new therapy patient. And beyond that, probably insulin would be the choice. How to treat diabetes in lactating mother? This question is from Mr. Sarathi Chakravarti. Very important question. Lactating mothers have a drawback of secreting the sulfonylureas in the breast milk. So if you allow the sulfonylurea to go into the baby, that will stimulate the beta cells of the baby and produce hypoglycemia in the baby. So metformin is a better drug, or insulin is a better drug, because insulin doesn't cross. Only insulin antibodies will cross the placenta during the initial time, and here the insulin will be in a reasonable level, controlling the blood sugar, and it doesn't actually is secreted in the milk beyond a particular level. So it is a safer one. And the next option would be insulin as well as metformin. These are the two drugs which have been recommended. For metformin, you try to take metformin after feeding the baby, so that before the next feed, the blood level of metformin will be much less. Next question is there any benefit of giving insulin if the person is already on insulin? Insulin resistivity. Probably he has mentioned that thought of insulin resistance. Yeah. Sometimes when the patient is a little resistant to insulin, adding OHA and insulin will be a better choice. A metformin insulin choice, a thiazolidinedione insulin combination will be a better choice. Sometimes even sulfonylurea, DPP-4 inhibitor and metformin and insulin would also be a better choice. In case you are dealing with a type 1 diabetes or in a situation like a growth hormone tumor or some other problems related to a very high insulin resistance condition like the congenital insulin resistance syndromes, the only way is to step up insulin and give a kick for the insulin resistance. So you increase the dose of insulin, thereby overcome the insulin resistance. That's the only way out. A question from Balamurugan. What is the percentage of diabetes reversal of drug-free lifestyle? Good. Of recent concept, this has been there. They have divided diabetic patients into 6 clusters. The cluster or a group of diabetic patients who have obesity, who have high insulin resistance. These are the patients who would respond very well for this reversal. So this type of patients, if they are identified within 6 years of diabetic life, if they are well motivated, if they could bring down their weight by more than 10% of body weight and stick on to lifestyle modification, then they would reverse. The incidence of reversal in diabetes population in general is very few. So 5% or less than that. Even 5% is a little more on the higher side. But if you are going to take out the cluster which would respond very well, it will be more than 5%. That is the percentage of reversal. A question from Sonam Top Gayal. Ideal insulin regimen for uncontrolled type 1 diabetes. The ideal regimen or a near normal regimen would be basal bolus therapy. That is what we have in our body. So whether you drink, dine, sleep or dance, there is a basal insulin which is secreted every 13th minute. So it goes on secreting like a pulse, tuck, 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 like that. That is basal insulin. And when you try to take a meal, this meal stimulates some insulin, and that is a meal-induced insulin, wherein you are trying to give a bolus insulin. So this is the best regimen. But the drawback is that you have to have 4 injections per day, little more serious monitoring. The chances of weight gain is more, and chance of hypoglycemia is little more. So to compromise this, you also have insulin pre-mixed and insulin analogs or co-formulation given twice a day, which is almost equal to the basal bolus therapy with less of hypoglycemia and less of weight gain. So that will be the regimen. Bala Vignesh, why Asian population is getting diabetes at a very young age, sir? How to prevent this? We have a genetic predisposition which is pushing us to a diabetic high risk group. Not only diabetes but also cardiovascular risk is higher in the Asian population. And what had been there in our ancestors, their lifestyle was much better. So lifestyle had less of stress, they had a very good sleep, they had a healthy meal. What I am trying to tell you is a natural, at the same time, more of a vegetable oriented as well as less refined meal. And also they had to necessarily have an exercise. If they had to go to the next village, they had to go by walk. Or they have to swim across a river and go to the other side. Today we have got machines, including the seaplane, which our Prime Minister has introduced recently. So you could land anywhere, you could go anywhere with a vehicle. So probably exercise is gone. Diet, it has become a fast food culture. And even child, I would rather say, the child is being now stressed. Even today in the era of COVID, there is online classes, online examination, which my grandchildren undergo, as well as the people like us are much stressed because of various professional, financial and communal areas. So all these things, apart from the genetic predisposition, are the reasons for the earlier or much more prevalence of diabetes. Prevention, lifestyle modification, careful diet, regular exercise, stress-free life would definitely be able to prevent this diabetes. Cataract risk and management I've already discussed. So thank you, Mr. Vinod Gupta, for congratulating me. Thank you. And Bala Vignesh, I've answered. And do drugs like Oglibos have a role? That's a good question. I've already mentioned about Oglibos and Acarbos. They fall under a category called alpha glucosidase inhibitors. They are very good drugs because they don't stimulate insulin, so they don't produce hypoglycemia at all if they are given as a monotherapy. And moreover, whenever this particular drug is combined with some sulfonylurea or insulin, there is likelihood of hypoglycemia due to the insulin or sulfonylurea. Beware, at that point of time, you will have to give glucose for a rescue and not sucrose or cane sugar. If you give cane sugar, it will be only at the stage of disaccharide that will not be converted into monosaccharide because you already have got a blocker. So if that is so, the hypoglycemia will not recover with cane sugar. So that caution you should take it. Another advantage of this alpha glucosidase inhibitor, except in pregnancy, you could give it in type 1 diabetes, type 2 diabetes, pancreatic diabetes, endocrine diabetes, obese diabetic, lean diabetic, and also in the pre-diabetic stage, alpha glucosidase inhibitors are wonderful. They are good drugs which could probably be used much more in our Asian population, wherein we have more of carbohydrate intake. From Vinesh Sukumaran, I missed that particular question somewhere. How to manage diabetic neuropathy, including neuralgia, from Sarathi Chakraborty. Diabetic neuropathy is a diabetic complication which is microvascular as well as macrovascular complication. The nerve fibers are affected by vasa nervorum affection as well as metabolic effect on the glucose. There is a segmental demyelination and remyelination. So this is what happens in neuropathy. So the treatment is tight glycemic control from the beginning, which would reduce the incidence. The second thing is diabetic control with insulin, because insulin has in some portion of its chain has a molecule which is similar to nerve growth factor. So this insulin, when you are giving it for glycemic control, sits on the nerve and repairs the nerve. So in that way, it may be useful. And another important thing is that it could even worsen initially, but the benefit will be more. Certain other things may not be that much rewarding, particularly after numbness has settled. If you have symmetrical, symptomatic, painful neuropathy, they respond very well to treatment. Amyotrophy with exercise, insulin, wonderful recovery. But when the patient goes in for numbness or autonomic neuropathy, the treatment may not be very fruitful. So Suganya Sendil, thank you for your appreciation. And one more appreciation from Mr. Banerjee, thank you. Where to add ACE inhibitor or ARB in diabetes type 2? Very important question. So ACE inhibitors or ARBs, very important role in the prevention of nephropathy. Most often the diabetic patients are getting hypertension as a comorbid condition. So it is almost like the bad friend. So diabetes always is a good disease with lot of bad friends like heart attack, hypertension, dyslipidemia, renal problems. So when these bad problems or bad friends come to you along with diabetes, you will have to check. And this is one drug which could stop and reverse nephropathy. So very useful. And so indication for ACE or ARB are proteinuria. Microproteinuria is a very good indication. The second one is that you have mild hypertension. If anything is more than 130/85, start them on ARB. Very important, so that you will be able to prevent that patient's deterioration as far as renal parameter is concerned. And another advantage is that you save a lot of arteries. So if you are able to save a lot of arteries today, you will not end up with endothelial damage, myocardial infarction, peripheral vascular disease. So be careful and try to take up this much more than the real indication. So I would thank Mr. Dr. Jawahar, Shivani Jain, Amit Bhattacharya, Aparna Vanmalli, Suganya Sendil, and Mahu Banerjee for appreciating me. Thank you.